just to get the admin stuff out of the way first, the meeting will be live streamed to the public, and a recording of the public part of the meeting will be available on the council's website within 24 hours of the meeting. Can I ask remote participants to use the hand excuse me, to use the hands up button to indicate they have a question or a comment. If you're attending in person, then you're required to wear a mask on entry to the building and meeting room, and which you can remove when you're seated. Would everyone, members and officers, please remember to switch their microphones on when speaking and off when they finish speaking, and speak directly into the microphone. And please switch off mobile phones or place on silent mode. Okay, apologies for absence.
Yes, Chair, apologies from Councillor Idris.
Thank you. Minutes of the last meeting, 2nd of March. Trust everyone's been able to read those, and are those okay? Thank you. Any disclosures of interest?
None that I'm aware of, Chair.
Okay. Any urgent business?
Again, none, Chair.
I have nothing to report on anything arising since the last meeting. So that takes us into the first item, update on COVID-19. Sally?
Hi, thank you. So the paper was circulated today, I believe. So it gives the usual update, but obviously we're in quite a different position now than last time we met. So as of the 1st of April, there's been a lot of changes to the guidance and to the response. So I think this will be the last report of this kind. So just as of today, our rates are 288 per 100,000, but because obviously there is a lot less testing now, so there isn't testing in the community in the same way as there was previously. I think those rates aren't a accurate reflection of the prevalence in the population anymore. So I'm not sure how much use it is looking at those rates at this current time, but the usual data is shown in the paper, so you can see that our rates are decreasing now in Luton, and we're well below the England and East of England average. Hospital is stable also. We do have cases within the hospital, but it's stable and decreasing. The main area of action now currently is around the vaccination programme. So there's a lot of work underway, working in conjunction with the NHS and partners around the vaccination programme and working to increase uptake. Our uptake is still pretty low compared to other areas in the UK. So for the booster, we're 5th lowest out of all of the local authorities. For dose 1, we're 19th lowest, and dose 2, 17th lowest. So there's a lot of work to be done still on the vaccination programme, but there is a lot of work happening on the vaccination programme. So the last 3 months, we've been working on an inequalities plan, so doing a lot of work trying to focus on certain areas and groups that have lower uptake. And I think I mentioned in the last meeting, I can't quite remember the timeline, but we were successful in securing some additional funding from the national government for COVID community champions, vaccination champions funding, and we've used a lot of that to do some work with the community and funding community groups to do some additional outreach and promotional work around the vaccination programme directly with the community. So could involve translation of materials, hosting an event, and we're supporting that through a mobile vaccination van that we have, which will be live imminently. We're just getting it off the ground, getting the branding right, and getting the plan for its where it will be when. So I've also in the paper attached so I've done some work going through the local outbreak management plan that we've had previously and that has come to this board previously, because we're in a very different position now in terms of our response that we can do and should be doing, because we don't have the data flows that we used to have. I've gone through that outbreak management plan and proposed what changes we should have in place. So we're stepping back a lot of our meetings that we have. So our weekly outbreak management meeting, we have stood down, and we will just stand it back up again by exception. Our health protection COVID specific committee meeting that we had fortnightly, we have stepped back to monthly for the next few months, and then I imagine it will become part of the health protection board that we have quarterly as an agenda item by exception. All of the changes are subject to change should the position change, should there be a new variant, should things escalate again, so that there is the flexibility there to step back up again as needed. As part of that, I do propose that the regular updates to this board as a standing agenda item stop, and that we start reporting by exception. So all of the other changes proposed and how we will manage are in the paper. There is still some flexibility in things we still haven't got the clarity on. So some of the data flows we're still not clear on, where we will actually be able to monitor the data effectively and do that surveillance piece. We're still working through, so we are meeting regularly with the team to work that out. And we're still having quite a clear role in care homes and management of care homes outbreaks, and looking at the guidance and informing care homes around their work, because there is still testing and quite a lot of measures in place in the care home setting due to the vulnerability of that population group. So I'll stop there and be open to answer any questions.
Thank you, Solly. Any questions?
He talked about I know we've said the government is saying it's a freedom day from God knows when. Last time we heard your report, but people are more concerned about the variant of interest. As you know, we've got the stuff, Omicron variant circulating, very infectious, that's our understanding. But the question, and if people are not going for immunizations, we know the immunizations that we've had is what we call waning down. And if more people are not being vaccinated, there again, the fear is people ending up in hospitals. So this is where I think we need to ask a question of the hospitals. But I think, Dr. Carter, we want to know, is hospitalization going up? Do you have a profile of people being hospitalized? And in terms of how we are coping, staffing levels, more people are getting infected. I think last week we had 4-point-something million people infected. How is that affecting staff? And what are we doing about it? So 2 questions. One, variant of interest, the sub-variant. If you are not testing, immunization uptake is low. What do we have? What mechanisms are we using? And then we need to think about hospitalizations. What is the picture looking like? And what are we trying to do? Thank you, Chair.
David, did you?
Yes.
Did you hear that? Sorry.
If I can come in yet, no. So the position at the hospital at the moment is that we have at L&D about just over 100 patients, inpatients with COVID, although not all of those will be in hospital because of COVID. Only a certain proportion of them will be. But I think we have to, one of the key things for us as a hospital is looking at the patients who are within our critical care facilities, because that, in the early waves of the pandemic, was where we were concerned about being overwhelmed, and because of the limited number of critical care capacity that we have. Now, at the moment, we don't have a large number of patients in hospital in our critical care facilities that are COVID. I think we've got 3 at the moment at L&D, when we've got capacity. Our overall critical care beds are 16. Our critical care is full, but not necessarily full with COVID patients. So I think the position now has become much more complex in terms of the position of the hospital. So whilst it is clearly of concern that we have 100 patients in the hospital, actually the consequences of COVID within the system and within society are also causing us problems. And what I mean by that is that we have obviously a large number of staff ourselves who are off with COVID. So about half of the staff who are sick at the moment and are absent from work are off with COVID. Although some of those will also be asymptomatic and not unwell, but not working because they're tested positive. But for us at the moment, we have extreme emergency pressures on our hospital, and that's because of a range of factors. It's to do with the fact that we are unable to discharge patients into the community in the way that we were, because all of the facilities we discharge into, all of the community services, all of the nursing homes are also struggling with COVID absence, and also the services which stop patients coming in the first place. And I think we're going to talk later about primary care access. All of those things aren't working as well and as efficiently as pre-COVID. So for us at the moment, our number one concern is about the emergency pressures that we face, and we've all seen some of the worrying statistics about ambulance delays and ambulance handovers across the East of England, across the country, and indeed locally. So that for me is, we have to look at the whole position in totality. So at the moment, in summary, we as a hospital do have significant numbers of COVID patients, but they're not translating into high numbers or unmanageable numbers of critical care patients. But the system is under extreme stress, not directly because of COVID or sickness in terms of inpatients, but because of the effect it's currently having on all of the way the system works. And that is the position we're in. So we're now going into a 4-day Easter break, and obviously we are worried. What normally happens within an Easter break is that we struggle to discharge patients over that period. This weekend could be much more difficult than pre-COVID. So I know that's a bit of a complicated answer, but I think for me it's not just about the number of patients with COVID; it's about the effect on the whole system, and that's what we're struggling with, and most hospitals are struggling with at the moment.
In terms of staffing levels, I think that's critical. You're saying some are being infected, which is shame to hear. How are we coping? That's a question. Do we have enough staff when there's an emergency that we are robust enough to be able to meet the requirement of patients? I mean, in terms of looting residents, how safe is the hospital now? Is it safest? Is it in the middle? I mean, those are the things people want to know. If I'm ill now, how long do I have to wait? Are people going to die because of the waiting list that we have in terms of ambulances have to wait? I heard sometimes people have to wait 7 hours for patients falling before they come to hospitals. I mean, to me, that's very critical. What are we doing about those things? And another question that staff were asking to look into in the hospitals is about cost of living crisis we have. Again, free parking, is that happening? How are we dealing with those issues? So all these combinations, how is the hospital dealing with that? That's something that I think it'd be good to hear from you on.
Yeah, so just coming back on a few of those issues. So in relation to, you asked about the safety of the hospital. Clearly, we as with every hospital at the moment, are struggling with the number of staff absence we have, which are higher than we would normally expect, given COVID. However, we do run a safe hospital, and everything we try and do tries to mitigate that effect. So, for example, in terms of getting other staff to do extra shifts, to do bank work, to bring in agency staff, to mitigate the pressures that we face. The questions about the ambulance delays are not necessarily a question for us as a hospital. We don't run the ambulance service itself, but the ambulance services struggle to offload ambulances is a consequence of the pressures in the system. However, yesterday, as an example, L&D and Bedford had the best ambulance handovers in the region. So we're really relatively doing well compared to our peers. And we do make sure that if our ambulances are delayed, and inevitably ambulances are often delayed, that we make sure that we that we keep those patients safe, and that we do everything we can to ensure that if an ambulance is stuck outside the hospital, that we assess that, we risk assess, and we make sure we get them offloaded as quickly as possible. In relation to I think you're alluding to the morale of the staff. I mean, clearly there are issues around morale, and we've had the National Staff Survey published over the recent weeks, which has shown there's been a decline in NHS staff morale through COVID in every single trust in the country, which I don't think is unexpected given the significant pressures they face. And on top of that, we have got a cost of living issues that affect our staff. There has been we have been asked to reintroduce the previous policies around staff car parking. So previous to COVID, we had a policy of charging staff for car parking. That was paused during COVID, based on instructions from the NHS centrally. That's now been lifted, and we can, if we so choose, reintroduce car parking charges. We've not done that at the L&D or Bedford at this point, recognising that we're a particular pressure point for staff in terms of the cost of living situation and in respect of the pressures that they face. However, we are looking to consult, take time to reflect, and to talk to our staff about what the right policy is, because I think there's a number of factors around car parking, including the green agenda, including the fact that actually some staff do want us to introduce car parking charges because it means that there's less pressure on the car parks itself. And as you know, at L&D, we've got particular problems around staff car park. But at the moment, we've not introduced staff car park charges. We did look at the staff survey, and we took a lot of interest in the staff survey that's been published. As a hospital group overall, we were 5th out of 13 in the East of England in response to the question, would you recommend your organisation as a place to work? And whilst I want to be top of that list, I think the fact that we have gone through a merger as an organisation, and secondly that that we've been hard hit locally by COVID, means that I don't think that was a bad result at all. So there is a morale issue within the NHS, and we're doing everything we can to ensure that we mitigate that and tackle that.
Thank you, David. Sally, I think you've got your hand up.
Yeah, I just wanted to come in on a related but slightly different point about testing. So although all the community testing is now stopped, there is testing, and David, you might have more up-to-date information than me on this because it's been one of the things that we're grappling with around the data flows, but there is testing for patients who are going into hospital. So it is still a way of monitoring and having good surveillance around increases and the risk in the hospital setting. So I just wanted to reassure Councillor Agbley on that point.
Yes, Sally, if I could just come back on that one. Yes, you're right. So we test patients on admission to hospital, and we test them through their stay. However, that's one of the issues which I referred to as being a source of one of the problems in terms of the flow of patients through the system. So through the pandemic, if we tested a patient within hospital who was perhaps asymptomatic and they came up positive, we then have to close that bay and keep those beds empty. That's one of the reasons why we have so much emergency pressure in the system, because the COVID policies have created, for good reason, but have created an inefficiency. So, for example, lots of beds which are blocked. Only this week the guidance has changed on that, allowing us to admit patients to beds where they're contacts of positive patients. But that's only been a change that's happened in the last week, whereas over the past 2 years we've not been able to do that, not wanted to do that. But I think we have to also understand the consequences of that. When the emergency pressures are so hot, if you're keeping beds empty, it does create a massive pressure in the system, and we've had to struggle with that. And it is one of the reasons why you then back up and you have ambulance handover delays and so on.
David, sorry, just to ask, in terms of paying for a lateral flow test, I think the government said only those who are dealing directly with patients. In your hospitals, is it every staff or is just those who work directly with patients? Because there's a dispute as to whether admin staff, those who are pushing trolleys, I mean, the support services, whether they're also entitled to free lateral flow tests.
Yeah, no,
Can you expand on that, please?
We give all of our staff who take lateral flow tests, we provide them with free lateral flow tests. So we're not asking staff to pay for it.
Thank you.
Jeff?
It's really for David. I heard a news report. I can't remember where now. I think I was in the car. That a lot of the patients with COVID in hospital are pregnant ladies who have not been vaccinated. Is this true?
Well, Sally might want to comment on this as well, but I think it's not true to say that a lot of patients in hospital are unvaccinated pregnant women, but I think we were and have been concerned about the level of non-vaccination within amongst pregnant women, and indeed we've seen some very sick women in hospital because of that. So it's not a large amount in numbers, but it's been one of the factors, and a very significant factor, which has created enormous pressure on maternity services nationally, and so we're incredibly worried about it. Now, clearly, some of the reasons why women have not been vaccinated is to do with a number of factors, but to do with concerns about vaccination for those women. But I think all the evidence shows that the risks of not being vaccinated are very significant for pregnant women. So it's not a large number, but the impact has been is significant, and it has definitely has been one of the factors which has increased the pressure on our maternity service. And many of our senior midwives have really made the point to me that it's been a factor for them and created some poor outcomes for them.
Thank you, David.
Can I just add to that? So I think, as David said, there was a few reasons why pregnant women have been a bit more hesitant to get vaccinated, and some of that was the national messaging at the beginning sort of wasn't completely clear on what path they should choose. But as part of our inequalities plan that I mentioned during my paper, we've been doing some targeted work, working with NHS colleagues around workshops and specific communication for pregnant women. So it is one of the groups that we're trying to do some targeted work with to overcome some of those barriers.
Okay, thank you. Anyone else? David?
In terms of the proposal, I'm not sure whether we should move to by exception now. If we are still living with COVID, I'm not sure why Sally thinks the report should be by exception. If we're living with COVID, I think we need to, for now, keep monitoring until if it's become endemic. As of now, instead of a pandemic, why are we going by exception? That worries me. It looks like the fact that UK is saying we are living with COVID, we are now in a pandemic still. As far as WHO and others are concerned, it's still a pandemic that we have. So why should we move straight to by exception? I think we should continue to bring the report here, living with COVID, until we have certified ourselves that yes, it's become endemic, that we don't need to worry about. Then we can let go. That's my personal opinion. Thank you, Chair.
Thank you, David. Does anyone else have any views on? Oh, sorry, Sally, please.
That's okay. That's fine. I'm happy to continue to bring reports into this meeting if that's the view. There will be a point that we will need to make that decision, and we can not make that today and keep bringing reports. They will change though, because the data that we have is much reduced, as mentioned. The data flows, with reduced testing, there isn't as much reporting on the data that I can be able to bring, but I can bring a situational update on sort of policy changes or anything else that is relevant. And a hospital update from David, as we've discussed today, is probably would continue to be of use for people. So it will change in its format, so there won't be as much data, and it will move to the kind of the direction of travel is to bring COVID in line with how we manage other respiratory infections like flu. So as we move to that way where it's always part of the sort of cycles in a winter annual basis, then we will need to keep it under review. But I'm very happy to bring the paper back next time. That's fine.
Thank you, Sally. Yes, I think we have a report for the next meeting and then see where we are then. Yeah, that would be good. Thank you. Does anyone else have any questions? Steve?
My point on this is Sally makes a good point in the sense that a lot of the details we're getting meeting by meeting is based a lot on currently the amount of people infected, and because of the government's decision, whether we agree with it or not, those numbers are basically not going to be worth the paper they're written on, because with very few people being able to get free tests unless they've stockpiled, those percentages and numbers we're getting will be completely skewed because very few people will be taking tests, because as you mentioned with this cost of living prices, that's not a cost that a lot of people are going to be able to afford to keep paying for tests to things. I would suggest possibly a good route, considering the other thing we were looking at with COVID specifically is we need to find ways of getting Luton's vaccination numbers up, is to maybe go to reports every other meeting, so to speak, with a kind of focus on those reports being primarily on where the vaccination numbers were and are, as well as looking at all the other details around it.
I don't know if you want to come back on that one, Sally.
Yeah, we still have the vaccination data and we'll still continue to have that, and it is our key line of defence now. So that will definitely still be part of a paper, and some of the hospital data we will still be able to get, but the overall sort of prevalence and flow of the pandemic, we won't be having that data anymore. And so we can report back on key actions or issues of concern in a more general kind of what do we need to do, what are we doing about it, and where are the actions being taken, rather than the level of data that we've currently had. And even those on that point that the councillor made around those, there won't be as much testing because only people that can afford it, even those that will just be buying their own tests, I don't think will be registering results in the same way, so it won't be part of data anyway. So the ability to look at the prevalence of coronavirus in the population as a whole won't be there anymore, so that won't be part of the paper.
Thank you. So at the next meeting, we can expect a report with the relevant data that's available, and then we'll reconsider the relevance of having reports at each meeting.
Yeah, sounds good. Thank you.
Steve?
Yeah, I'd agree with that. Yeah, to have it come to the next meeting with a view to potentially going to a less consistent basis and looking at a way of how best for us to view figures that are actually useful.
Okay, thank you. Anyone else have any more questions? Okay, thank you. Thank you, Sally. Thank you, David. And next item, primary care access in Luton. Nikki.
Hi, thank you. So hopefully you've all had the paper and had an opportunity to look. So if I just pick up some of the salient points, is that the primary medical services access is key. is absolutely key to the system working. And David earlier was mentioning about the heat in the system. And as we all know, we've had many conversations here, primary care access is absolutely critical in the sense of people accessing services. And I say the GP practice services, and that's that multidisciplinary team before they go into crisis point. But in the paper, we're very clear that primary medical services is a 365-day service, 24/7, and that's where we have to have the inclusion of what we have, the 111, which is the front end of the service. And then we have something I've mentioned before, we have something called the directory of service. So if a patient phones for urgent same day, they will have their needs assessed. For example, it may be the mental health crisis team, it could be the end of life, it could be the children's services. So just want to put that into context. The paper emphasises there were 94,000 appointments in January, and that just gives you a ballpark figure, slightly more than December. For this paper, we've really focused this time on communication, workforce, and in particular the Winter Access Fund. I mean, the Winter Access Fund has been and gone because that ended on the 31st of March. But to put the context, we had funding through from the region to support primary medical services, and that was basically more appointments, which we had to justify. I think one thing that Luton did really well is we worked with Age UK Luton, and that was very much on the end of the frailty work. And I know we've spoken about patients with frailty, and that actually links in with the Bedfordshire Care Alliance. It's getting that proactive, anticipatory element. I just want to also pick up, because when we talk about primary medical services and access to it, it's multifactorial. So I've just mentioned there about the urgent same day access. What we're really recognising, and this is a national issue, is that there are a number of patients, so those people with frailty are a very, very good example, need that continuity of care, those proactive, anticipatory, and it's those care navigators. So in the paper, it shows you the 6 work streams. And I think for me, that is really, that's really important. And that's what we put in as Appendix B. Just looking at the actual work streams. So for example, when we've actually mentioned in there about the GP primary care network workforce, I've given you the numbers of the additionality, and I know this was discussed yesterday at the place board, because I can see Mark on the call, about the additionality of staff. So a number of those, they're called the additional staff reimbursal, additional staff role reimbursal, but those staff are particularly looking at that higher acuity end of patient need. The only other bit I really wanted to home in, and this was very much, Chair, from we talked about in the scrutiny meeting previously, is about the communication. So within there, and I mentioned the interface with the place board. So just for clarity, as part of our working collaboratively as the system, there is the Luton Place Board, and that actually met yesterday. And one of the 6 priorities in there, which is bespoke for Luton, is how we help our population to access particularly urgent prime medical services. And the 3 areas that have been focused as a need is people with serious mental illness, people with learning disabilities, and end-of-life care. So I just wanted to make that parallel between the 2 work streams within the Luton system. But I think the most important for me, which is written in this paper, is about how we build that confidence, and that's the confidence of our population about using the services. We've previously mentioned that if the primary medical services offer isn't correct, we then have what I call seepage to other parts of the system. For example, people using the A&E department where it wouldn't be the right place. Now, we're fortunate because we do have at the front end, we have a triaging approach. And if people have primary medical needs, basic primary care needs, they are filtered through to the GP urgent treatment centre. Sorry, the GP, the urgent GP centre, which is the front end, which David services David is part of the hospital service. Well, I looked at the data prior to today of everybody who is arriving in the A&E department. We are easily seeing 30% are automatically being fed through. So what we've got to work, and that has to be a joint system working, and this is where I really want to be working with yourselves in the communications, is that we do know there's capacity. And we've actually, we're doing the data analysis. We do know there's capacity within the primary care element. And one of the work streams that the team are working on at the moment, and that's with system colleagues, particularly people in the acute trust as well, is the urgent care work stream. And that is, for example, the confidence of Luton population knowing that if they ring the 111 service and their need is assessed as requiring A&E, they will have we call it a notice that will go to David's team in the A&E, and they will know to expect people that have been triaged in that way. But we've really got to collectively together have the simple message that ring your GP practice if you're able. If you can't get through, because we know that some of the 26 practices haven't got great telephony, is that if you can't get through and you've got an urgent same day need, you can ring the 111. There is the opportunity through that route to have a directly bookable appointment to your own GP practice. And if it's assessed as needing A&E, you will again have that opportunity where you will be guided, you'll be supported, the patient will be supported to go to the right place. So I really would listen to any comments you have. It is ongoing work. We've got Sarah Frisbee, who is a member of the team, who is leading the communications work stream. So tonight, if there's any members of this committee who would like to join, we're doing some focus work, we'd really welcome that. So I'll listen, Chair, to any questions.
Okay, thank you, Nikki. Anyone have any questions? David.
Thank you. And communication, as we know, is really important, and the way primary care is provided now is changing, and most people just get up and go to GP. What I'm mainly concerned about is, I think on page 13, bullet point 13 talks about communication campaign, workforce, and reintent access. In terms of workforce, GP workforce, I think the 5-year plan promises us to increase the number of GPs so that we can have more access to GPs. The report that I got from some of our residents is when they've been sent out, they're not seeing qualified GPs, but something like allied professionals. So my question is, did we get the number of GPs required? If they've been retirement, have they been replaced, or they've been replaced with allied professional, not qualified professional? Because if I'm not well, I want to see somebody who is a medically qualified, not somebody who is allied. What does that mean? So the question is, have we got the number of GPs we need in terms of per patient? And what has been promised in terms of the GP plan, 5-year plan, has that happened in BLMK? Thank you, Chair.
So that's two slightly different questions, and I will just try and tease out the two. So there is a national workforce achievement that we are all having to work through. So Dr. Nina Pearson, I know you're aware of, chairs the training hub, the primary care training hub. So our overall GP numbers in our BLMK system are very slightly up. I think it's about 4, so it's not a material, but I think to members of this committee, they've not gone down. But and we also have numbers for nurses and the additional role reimbursals. The whole point of the new ways of working is that, for example, a well-qualified community pharmacist will be able to facilitate and support patients with long-term conditions as well as what you have traditionally seen a GP. And I think, in fairness, that's where we've all got to work together because that's not just primary care. I'm looking at David within secondary care, is that it is a way of working with multidisciplinary teams. I know specialist nurses increasingly do work that traditionally was always seen by a consultant. So I can share with you workforce numbers, because believe me, I'm being asked that all day, every day. So I can give you workforce numbers, but for total numbers of staff into the GP practices, there is an increase, and that's what this paper is showing.
Thank you for that. But as you know, the BLMK, we were promised numbers-wise, it's going to go up. That's what I'm trying to know. Has that happened? If not, what are we doing? Because the population is going to grow, and ratio of GP to residents is really critical. Otherwise, then the seepage you talked about, they all end up in A&E, and that's the last thing we want to see.
So, Councillor Appleby, now with the national collection of workforce data, we know our workforce data, and so we can see an increase. And believe me, the additional role reimbursals is where the investment has been made into primary care. So the numbers are considerably up, and you can see for Luton, and I've put what those numbers are. So I can give you the total numbers if that's helpful. But yes, in answer to your question, being clear, there is an increase in workforce. However, your point is very valid. I mean, you read it in the paper today, for example. I read it about the numbers of workforce, and it was particularly GPs that looking to retire early. So workforce, believe me, is probably my biggest concern, and where we're working in as a system, and that's particularly working with yourselves, council, because it's all about working with universities, it's working with the colleges, and there hasn't been the investment in recruitment of general practice, hence why the national team raised this as a priority, 3-4 years ago.
David, did you have your hand up?
Yes. As Nikki pointed out, we do have the experience of running the urgent GP centre at the front of the L&D site. In response to David's question about GP numbers, I just do think we just need to look at this in a different way. Most of the patients who attend GP surgeries do not need to see a medical professional necessarily. That what the model for me that works is having much larger primary care, much bigger scale. And if you achieve that, then you don't necessarily need more GPs. You can ensure you triage patients to what they really need. So that might be a GP, that might be a physiotherapist, that might be a pharmacist to look at their medicines management, that might be a psychologist to deal with their mental health issues. So I think we will not be able to nationally find the number of GPs, but in my view, we don't need that number. What we need is to reconfigure primary care into much bigger scale. And at that point, when the patient walks through the door, they see the most appropriate person, which may be a GP, maybe a medical professional, but that will not always be the case. Whereas at the moment in Luton, we have got very small scale primary care. We've got 26 different practices in 34 buildings. That is very, and if you have that model, which we do, then you do need GPs because it's impossible to have anything else. But if you create a different model, and it's the model that I hope we're trying to create in Luton over time, we'll end up with a situation where the GPs that require is not necessarily the limiting factor, and we'll have actually a much better service for individuals, because if a patient needs to see a physiotherapist, that's who they should see, not a GP. You need to make sure you triage patients at the front to say what is the right service for these patients. But so much of the work that comes into primary care could be dealt with by a physiotherapist, a psychologist, a pharmacist, and so on.
Okay, thank you. Pat.
Hi, can I just add, Healthwatch has had some really positive feedback this week on new telephone systems within 3 GPs. where that you don't have to hold on and be 33 in the line. Once you make your call, somebody then phones you back, which is, really positive feedback on that.
I really appreciate that, because that was one of our initiatives with the Winter Access Fund. So, and that should be what we should expect from all practices. So thank you for that.
Thank you. Steve.
So that system, other than other systems that might be more advanced than that, do we expect to have that system in every single practice in the borough? Because obviously I haven't actually. Oh, brilliant.
Yes. Yep. So that is. So I'm working very, very closely with our digital teams and regional teams. Exactly that. And that's something we've been lobbying for quite a period of time, because poor telephony is, that is one of our issues, one of the issues that could have been easily resolved. So yes, absolutely.
That's good to hear.
Okay, Nikki, I have a question about on page 13, bullet point 11. Of the total appointments offered, the percentage of which were face-to-face appointments across the 26 practices ranges from 33% to 99%. That's quite a variation between practices. Why are some practices offering 33% while some practices are offering nearly 100%?
That's a very, very helpful question, and it is something that from a Royal College of General Practitioners is what is the right percentage. So we are aware that some GP practices across the BLMK system, and including Luton, have wanted to go back to total face-to-face, and we don't think that's possibly the right thing to do. So it is that balance. So, and I think that's where David's point is about, we've got 26 practices. They have contracts, so we are working and influencing them, and that's where working with Health Watch is just crucial, because it's about the experience. So we know that through the national work, that certainly between perhaps 30% of all primary care requests could be dealt with very successfully remotely. Now we're absolutely aware, and that's one of the first things we do, is addressing the fact if people haven't got technology or haven't got English as a first language. So it may be that some of the practices, and we've worked with them, they've got a population that just don't get on with the digital. So there's no right and wrong, but we just need to be very, very clear with practices if they can justify their percentage being 33, or if they can justify it being higher, 90 or whatever. So we triangulate patient experience, actually the use of the practices population to other services, for example, urgent care, A&E departments. So we do a whole multiple areas of, look at a number of metrics to identify and work, basically facilitate the practices to put the model that's right for their patients.
Okay, so is it a matter of negotiation with the individual practices about what the correct level of face-to-face appointments should be?
Yeah, I think I would use the word facilitation rather than negotiation, because we are really aware that some of our practices have far more boroughs with more need and where there's more inequality. So it may be correct that those people actually have 99% face. So for us, it's to understand variation. So it's for us to facilitate and make sure that it isn't just what the practices fancies doing, is where it's meeting need. That's the important thing, and that's why we need to just cross-reference or triangulate with patient experience, as I say, and what the outcomes are. Because what the worst thing that can happen is if patients give up, and we've had some of those really tragic patient stories where they tried and they couldn't get, just couldn't get through, and then they deteriorate 2 or 3 days later, and then they become an urgent when they should have been, a planned appointment. So again, that is where we have to be working collectively as a system, but we absolutely, it's getting into the devil of the detail of the data.
Thank you. Does anyone else have any other questions? Okay. Thank you, Nikki. Next item is the adult social care strategy.
Good evening. Can everyone hear me okay? So,
Yes,
oh,
sorry, can you
hear me okay?
Yes. Can you
Sorry.
introduce yourself and
You can hear me, yeah? Sorry. That confused me slightly, sorry. My name's Tamara James. I'm the Service Manager for Strategy Engagement and Implementation within Adult Social Care. I'm here with my colleague today, Elaine Healy, who wrote the strategy. The purpose of today is for us to present to you the final version of the strategy and for HS, CRG, and to note the content of the report and provide any comment as appropriate. I trust that you've all had time to read the report. My previous visits to Scrutiny over the past few months, a lot of this information that you've seen. So I'm just going to focus on the salient points for today. The strategy sets the scene for adult social care reform. It's an overarching strategy. I think what I really want to highlight is that this will be a live document. It's not going to be a document that sits on our shelf and we don't do anything with it. It will be reviewed on an annual basis. It will have an implementation plan attached to it, which will be monitored and reviewed. Within your pack, you can see from pages 20 to 46 that it shows you the adult social care strategy. It's a simple strategy. I feel it's been written in a simple way. It's flexible to accommodate the changes required from the reforms that are coming down track for us. On pages 47 to 52, you can see the implementation plan, and that will be the focus for the adult social care strategy to ensure that we deliver on what we've set out within the strategy. And as I said to you, the implementation plan will be monitored, reviewed, and updated to ensure that we complete the tasks that we've set out. On page 53, we've got a more simple strategy on a page. To help you just see in one page what it is that we're setting out to do in the adult social care strategy. And in pages 54 to 59, you've got a summary which you can share further, which highlights to you, which I've mentioned before, the context of the strategy, challenges that we're facing, the vision and the outcomes that we want to achieve through the strategy. What I wanted to focus on was page 59, which tells you how we will deliver on our next steps. Our commitment is to ensure that we put the population of Luton at the centre of everything that we do. As I said, I feel it's really important that this document is reviewed. So we plan to review the implementation plan in line with the strategy on a quarterly basis. And we hope to do this or anticipate to do this in a co-produced way and update the strategy and implementation plan accordingly. We want to enable independence, so we want to be able to help people to live well and age well. We know that we have to focus on integration to improve care and support outcomes. Our strategies in here are aligned with the ICS strategies. That's important for us to be able to work in a collaborative way. We plan to address the issues and needs of the workforce because that will help us deliver on the things that we set out as part of our priorities. We hope to be innovative and sustainable, and I think this is a key strategy to help us deliver our Luton 2040 overarching mission of ensuring that Luton is a place that thrives, that we have a strong, empowered community, and ultimately helping people stay in their homes for longer. We recognise, and some of the feedback from policy a couple of weeks ago is that we can't do this in silo. We have to work collaboratively, and this will be reflected in the implementation plan to ensure that we deliver on what's set out in the adult social care strategy based on the reforms that are coming down track. So that's a summary, nice and succinct, I hope. Any questions? Thank you.
Thank you, Tamara. Yes. Yeah, just to agree with you. It's very clear and very readable report. Does anyone have any questions?
That's unusual.
Okay, I'll have a few questions. So the report mentions talks about focus groups and co-production groups when we're talking about consulting with the population. Are they the same thing? And what is a co-production group?
Do you want to answer that, Lee?
So co-production is when you go on the journey together with the individuals you support and with the population. So it's not the council just writing a strategy and making decisions. It's more about being on the journey together. So part of the initial feedback from this, and it's been quite a journey. We started in around June last year. It was very much an engaged approach with focus groups in place to take people on board with us. It has taken a slightly different turn because of Building Back Better and People at the Heart of Care, recent white paper that we had in December. So our focus very much has transitioned to reforms. And as we've touched under other agenda items, communication is key for us going forward. We've kept it broad as an overview just to give it that flexibility within the policy. But very much going forward, this would have more of the community voice coming out through it. It's more about coming through the executive process now because we got a bit constrained with the reform parameters that came down and taking it forward from there. So really in future, having that significant group and with our partners such as Healthwatch, etc., who we initially engaged with, continuing and actually getting feedback on our performance. So this is very much we said and reflecting on that with people as well.
Okay, how often will these groups meet?
So we haven't established them yet because of the reforms, but we would expect with every quarter having an update that they would also happen quarterly in line with that. So it would be a kind of set out position, whereas it's falling for the next update, that co-production group would meet in advance of that. So it's a reflection of the strategy as it is, the implementation plan, and obviously the next version then takes into account and updates in that way. So we've tried to keep the language very user friendly as well. We haven't brought in, we've highlighted legislation, but we haven't taken it out of the context of what we hope the population will understand.
And can I just come in on that, sorry, as well, Chair? Alongside that, our commissioning colleagues are looking at resurrecting our older person partnership groups and learning disability groups, and that will also form a part of co-production going forward.
Thank you. So one of the aims detailed in the paper is developing a highly skilled, fluid and resilient workforce. I imagine at the moment there must be some challenges associated around that.
Yeah, so I think everyone appreciates that workforce is a challenge in general across a number of sectors. So for us, and workforce obviously is in there, but people at the heart of care, that outlines how the health and social care levy that we'll all be aware of is being spent. So there is some ring-fenced funding within that for the workforce, and there's a number of priorities in there. So for the social care sectors, that might be care certificates that carers would be complete, being portable between services. It would be about career pathways, etc. So we will be obviously working within the parameter of those reforms and with our learning and development teams and keeping workforce strategies up to date in that way.
And just to come in on that, sorry again, Chair, the workforce strategy is also currently being updated to reflect the national and regional challenges that we're facing, and that will include the actions to obviously include how we improve our workforce and retain staff as well.
Thank you. The question about, so you're obviously working within the BLMK framework. It also talks about the report talks about working at a regional level. Is that Is that the same? Is that the same thing?
As a sector, we have ADAS, the Association of Directors of Adult Social Services. So we participate in regional groups in that way. So as a region, we might sign up to initiatives such as Making It Real, which is things you'll find outlined in the strategy. So that's I statement. So that's what the population would be able to say about social care. You know, I have the information I need, for example. So it's very much person-centred. It's very much strength-based approach. And Making It Real also has we statements. So that would be what we say as a local authority. So we provide people with the opportunity for A, B and C, for example. There will also be, because of the reforms, and you might remember the journey we took under the Care Act, there will be regional and local government association support in terms of some of those reforms as well, because they are very, very challenging, very wide ranging. So yeah, we're always part of the region, always participants in anything that happens in that regard.
Thank you. Does anyone else have any questions? Okay. Thank you both for
Thank you.
very good reports. No, obviously a lot of hard work has gone into it. From a personal point of view, I think it's good that taking an integrated systems approach. You were talking about not working in silos, and I think it's important when you were talking about. I think it comes out to the point about adult social care. It's not just about older people in care homes, even though that is important, and it's also about mental health and domestic abuse, and integrating those aspects and similar aspects into this policy. Yeah. So yeah, thank you very much. Yeah. Sorry. Yes. Okay, thank you. Draft work programme.
Yeah, thank you, Chair. Members have before them the draft work programme and also a copy of the current forward plan, and it's members' opportunity to add anything to the agenda, or if they're happy with the current work programme.
Yeah, 62. Okay. 61. So we have impact on the population of COVID on Luton, BMK update and primary care update, and our 6 monthly progress on the impact of universal credit. Does anyone else have anything that they would like to add? I think it would be useful, considering the adult social care report, that in the 1-year plan on page 49 and 51, that if we could have a update on how that plan is going at the September meeting. Mark, would that be possible?
Yeah, that makes absolute sense. So yeah, we can arrange for that to happen and comfortable we add that to the plan.
Thank you. Thanks. Thank you. That's it. Yep. Thank you very much, everyone. Thank you, everyone who's the reporting officers for their reports, and anyone who's all the contributors